The Hilton sale is on. Now through September 29th, you can save up to 20% on stays this fall and beyond. Long weekends, last-minute getaways, holiday gatherings. There's a Hilton stay for all of them. More moments, more experiences, more destinations. Now 20% off for a limited time because it matters where you stay. Don't wait. Book by September 29th and save up to 20% at Hilton.com. Terms apply. Hilton for the stay.
This episode is brought to you by Nespresso and Samra Origins by the Weekend Coffee Collection.
Introducing Samra Origins. My collaboration with Nespresso is a connection to my roots, to my mother, Samra. Coffee that hits the right notes. It transports you. Crafted with unique notes and bold, soaring flavors. Experience a taste that moves you. Nespresso and Samra Origins.
Discover more at Nespresso.com.
Sickle cell disease is an inherited blood disorder that affects around 15,000 people in the UK alone. It's the most common genetic blood disorder in the country, and yet a lot of people don't really know that much about it or might not have even heard of it. We'll be hearing from two really important voices across the landscape of sickle cell disease to find out how the disease works on a scientific level, but also on a patient level as well. Before we get started, it's important to mention that we will be discussing some sensitive and potentially triggering topics in this episode. Starting at 27 minutes and 21 seconds, when talking about the emotional and mental impacts of chronic health conditions, the topics of depression and self-harm are mentioned. If this is a subject matter that might be triggering, feel free to skip to 32 minutes and 31 seconds. There are also some resources in the description of this episode if you are struggling and need some support.
So my name is Stephanie George and I have sickle cell disorder. I am the oldest of three. So I have sickle cell, my sister has sickle cell, and my brother is he carries the gene. I used to work as a midwife in the NHS. And now I do work with, I work with the Sickle Cell Society and I'm a peer mentor. So we mentor kids and young adults who have sickle cell disorder.
I'm Sara El Hoss. I'm a researcher at Institut Imagine in Paris. So Institut Imagine is the Institute of Genetic Diseases that is located in the Necker Hospital campus. And I co-lead the red cell and erythropoiesis group in the hematology laboratory that is headed by Professor Olivier Hermine. And in my group, we work a lot on sickle cell disease, so on understanding the pathophysiology of sickle cell disease.
Sarah, thank you for joining me from Paris. Could you start off by just explaining what sickle cell disease is and also your own journey and how you ended up as a researcher in the field?
Thank you, Leah, for having me. It's a pleasure for me to be here in your podcast and to speak about a topic that is very dear to my heart, which is sickle cell disease. So here we're talking about a genetic condition that is caused by mutation in the beta globin gene. And this is when we say genetic, it means inherited. So this is an inherited mutation that is autosomal recessive. So what we mean by autosomal recessive, it means that both parents have to carry the mutation for the child to develop the disease. And what brought me to work on sickle cell disease, it's actually my life story. So I come from Lebanese parents, but my dad immigrated to Nigeria when he was very young. And so I was born in Abuja in Nigeria. And so I was born in the country that has the most sickle cell patients in the world. And so I was always surrounded by sickle cell patients who were my friends, my teachers, my nanny, and others. And I always wanted to give back to this country that gave me my childhood. And this is why I wanted to pursue working on sickle cell disease during my career.
What happens in the presentation of the disease if just one of those parents has the mutation?
The mutation, let's call it S. So the sickle mutation, we can call it S. And when the individual is not mutated, we say he has the A gene. Why do we say S and A? Because S stands for sickle and A is the adult hemoglobin, because what is mutated is the hemoglobin. So if the father or the mother has only has one allele, so they are AS, and the other partner, so the other parent is AA, then the probability that the children will be sickle, which should be SS, is 0, because you need to have both parents having the S. And so, but some of the children could be carriers. They could be AS because one of the parents still has the S. And this we need to keep in mind when the child himself is building his own family. So he should be aware that he might be a carrier.
You said that the mutation is in the gene for beta hemoglobin. What is beta hemoglobin and what does it do when it's functioning normally? And how does that change when you've got this mutation?
So this is a very interesting question, Leah, because when we understand what the beta gene is, then we really understand the sickle cell pathophysiology. So let's start from the red cell. So in our blood, we have cells that are called red cells, and these are the cells that give the red color to our blood. And these cells, their job in our body is to help oxygenate the organs and oxygenate the body. So they carry the oxygen. For them to be able to carry the oxygen, they really depend on a protein inside these cells that's called the hemoglobin. In sickle patients, this hemoglobin is altered. So instead of them to have a normal hemoglobin, they have a sickle hemoglobin, which has the sickle mutation. And so hemoglobin is usually composed of 2 alpha chains and 2 beta chains. And in the sickle patients, the beta chain is altered due to the mutation. And therefore, this could alter the job of this hemoglobin, and it will not allow it to carry the oxygen the way it should in the body. One very important point about this hemoglobin and why it's called sickle is because it has the capacity to sickle inside the red cell. And so the sickle patients, they have red cells that look like a moon, or if we want to add a French touch, we can say like a croissant. And while in healthy individuals, we have these round red cells that are biconcave and that are flexible. The characteristic of this sickle red cell that make it really not good for the sickle patients is that it's very fragile and it can not deform easily. It doesn't have good elasticity. And so when it's passing in the little veins of the patients, it can either get stuck in the vein or it can hemolyze. And this means that the patients will have less red cells and therefore they might be anemic.
Could you talk us through what these symptoms might look like and what the diagnosis process is like?
Sickle cell disease is a disease that will manifest very early in age. So the patients will have symptoms quite early in age because as we discussed earlier, Leah, this disease is going to impact the shape of the red cell. And so these red cells that are going to have this moon shape and they are stiff, they can easily block in the different organs of the patients because all these organs are surrounded by blood vessels. And so the patients will suffer from 2 different complications. The first is anemia, because unfortunately these red cells are going to hemolyze in the circulation, and so the patient will have less red cells than a healthy individual, and he will be anemic. And the second complication is pain, and the pain is due to the vaso-occlusive crisis that happen in the patient. So maybe I will give you a small introduction of what vaso-occlusive crisis is. It's from the name of the word where we hear the word crisis, so you can imagine how painful it is for the patients. So vaso-occlusive, it means that these red cells, because of their abnormal properties, they are going to block the circulation of the patients, and therefore the patient will have pain caused by the accumulation of these cells and their aggregation in the circulation. And so these are the two main hallmarks of the pathophysiology. And very recently, us and other researchers has shown that inflammation is also a hallmark in sickle cell disease, and it could be feeding into having more pain, because we can imagine that when we have high inflammation, we have pain, and the vaso-occlusive crisis could cause high inflammation. And so it's like this vicious circle.
In Stephanie's case, it's been a huge part of her life for as long as she can remember.
My mum said I think I had my first sickle crisis when I was like 14 months old. So I'm the oldest of three, so my parents didn't know. I think they knew about sickle cell, but they didn't know that it was in their family. They didn't know anybody who had it. But I know they would have. My mum told me that they heard about it and they knew about it, but they didn't know anyone closely related to them that had it. My mum said I think they found out when I was about 6 weeks old. I think I only started noticing differences maybe when I was about 7 or 8, because you would have those episodes of like excruciating pain, but you wouldn't know that that was not everybody else's norm. It's only like when I started going to school, like you start noticing that I can't run and play like my friends would do, or I had to wrap up warm when it was the winter, and some of my friends didn't have to do that. And then when I was 9, I had a stroke, which is a complication of having sickle cell. This is one of the complications of having sickle cell disorder. And obviously that changes everything. I didn't understand what it was. Obviously, yeah, by this point, you're going to your, hematology appointment. So with the pediatric team, I just noticed like from about, 7, 8, I noticed they were doing a lot more tests. So they would do like screenings of, so it's called Dopplers, but they would do like screenings on your head. And then I guess that's just monitoring the blood flow and stuff like that. And then I would have a lot of like MRI scans. But I didn't really understand what was going on until the stroke happened. And obviously they had to explain, and I think it is quite hard for an adult to have to explain to a child, okay, this is what's happened to you. This is why we've been doing all this testing. Even till today, sometimes I'm just like, I can't even believe I went through that and that I survived that, because it is really a really, really, really traumatic experience. Things obviously changed after that. I started having blood transfusions when I was 10 years old, because they said that would hopefully reduce the S percentage each time that I do it, and it will reduce the chances of me having another stroke.
Something that is a key part in someone's experience with sickle cell disorder is the transition experience, which is going from the pediatric department in a hospital up into the adult care.
Yeah.
So how was that experience for you?
It was hard because when you when you are a child, there's certain things you just won't understand, and they will, and sometimes it's just easy for them to sort it out, just to deal with it, and I don't have to worry about it. So they do try and prepare you for it, but I don't think it's enough. So when you're like 16, 17, for me anyway, the adult hematologist was coming into my pediatric clinic appointments, so you can kind of get used to who you're now going to be seeing when you get to 18. But it just felt like once you're 18, okay, you're on your own. Like you just get thrown out almost. With pediatrics, it was amazing because obviously you have, the unit is built for pediatrics. So you have toys, you have things that you can keep yourself busy with while you're waiting to even be called in by the doctors. When you were sick, so from what I remember, my parents, all they needed to do was just call the ward, the children's ward, and say, oh yeah, she's having a sickle cell crisis, and that was it. And they'll just be like, oh yeah, we've got a bed, just bring her. There was never anybody saying stupid things about, or whether it's you don't look like you're like this or whatever, or you only here for the drugs. That never happened in pediatrics. Things were made simple for you to understand what's happening to you, but also because you had a lot of support from your parents, and that makes a big, big difference. And I guess that's why I'm so happy that I do the peer mentoring, because we're able to kind of be there with them when they're, when they're transitioning. So when they're moving from pediatric to adult services. And I think that also helps them to know, okay, yeah, this person's gone through that. I'm glad that I can have someone to talk to me about it, or, you know, if they want, we can attend their, you know, we can go with them to appointments.
Growing up in Nigeria, a lot of the community around you would suffer from sickle cell disease. And this is a condition that disproportionately affects people with specifically sub-Saharan African and Caribbean heritage. Why is that?
So this is a very important point to discuss. So I'm gonna try and explain to you why we find most of sickle cell patients in sub-Saharan Africa. But I think we have to keep in mind that in 2025, like in our recent times, sickle cell disease is not a problem only in sub-Saharan Africa. It is a global problem, and sickle patients are present in all over the world, and I can give you some numbers later. But historically, sickle cell disease was present in sub-Saharan Africa because this S mutation, when we discussed earlier about AS, having AS mutation protected the individuals from having malaria, which you know is really present in sub-Saharan Africa, and it is deadly. And so this is how the number of individuals with AS increased. And when an AS marries another AS and have children, you have 25% chance that they will have SS children, so sickle children. And this is how the mutation or the disease became prevalent in sub-Saharan Africa. Sickle cell disease is now not only prevalent in sub-Saharan Africa, but it's a global health issue, and it was actually recognized by the World Health Organization as a global health issue. And if I want to speak about Europe, studies that were done in 2017 that are a bit old now, but at least they can give us an idea. They show that there was approximately 15,000 sickle cell patients living with sickle cell disease in the UK. And in France, we have approximately 25,000 sickle patients living with sickle cell disease. And you can imagine that these numbers have increased since the study was done. And actually, one thing that I think is important is we do need new epidemiological data about the presence of sickle cell disease in Europe.
Sickle cell disorder is very much not a condition that everyone has an equal likelihood of getting.
Yeah.
Do you think this, for you personally, or just the experience of other people you've spoken to as well, do you think this has impacted the awareness of it and maybe even your diagnostic experience and just how much it's spoken about as a disease?
Yeah, definitely. Sickle cell is the fastest growing genetic condition in this country, and a lot of people still don't even know what it is. They don't even know that this thing exists. Something that affects almost 18,000 people in the UK, and the fact that certain people may not have even heard of it. If this affected a lot more people and people who weren't from, an Afro or Caribbean descent, and I have to be honest, if it affected white people, we wouldn't be in this situation. I do believe there would be a lot more, whether it's research, because there's not enough research about sickle cell, whether it's obviously funding for treatments and funding for just, helping patients to try and live their lives, because that's all we really want to do.
This episode is brought to you by Indeed. When your computer breaks, you don't wait for it to magically start working again. You fix the problem. So why wait to hire the people your company desperately needs? Use Indeed's sponsored jobs to hire top talent fast. And even better, you only pay for results. There's no need to wait. Speed up your hiring with a $75 sponsored job credit at Indeed.com/podcast. Terms and conditions apply.
Mint is still $15 a month for premium wireless. And if you haven't made the switch yet, here are 15 reasons why you should. 1, it's $15 a month. 2, seriously, it's $15 a month. 3, no big contracts. 4, I use it. 5, my mom uses it. Are you playing me off? That's what's happening, right? Okay, give it a try at mintmobile.com/switch.
Upfront payment of $45 for 3-month plan, $15 per month equivalent required. New customer offer first 3 months only. Then full price plan options available. Taxes and fees extra. See mintmobile.com.
Casgevy was approved for use by the NHS earlier this year, which we'll get onto. But looking back historically, what have the traditional treatment methods been for sickle cell disease, and how have they changed over time?
We currently have palliative treatments. So these are treatments that are meant to decrease the symptoms of the patients. And we have only one curative treatment that I will talk about in a bit. But the palliative treatments that we have at the moment are hydroxyurea. So I'm sure you've heard about this drug, which is one of the main treatments for sickle cell patients. So hydroxyurea is a drug that is going to increase the level of fetal hemoglobin in the patient. When we are children, so when we're infants, so during the development of the fetus, the first hemoglobin that will be produced is the embryonic hemoglobin, and then we switch to the fetal hemoglobin. And then after the birth of the baby, this is when we start to have this adult hemoglobin. So during our lifetime, we start with the embryonic and then the fetal and then the adult. In sickle patients, it is the adult hemoglobin that is mutated, but the fetal one is okay and the embryonic one is okay. And so what we try to do with hydroxyurea is that hydroxyurea has the capacity of increasing this fetal hemoglobin in the adults, and therefore this will decrease the sickle hemoglobin, and so the patient will feel better because he will no longer have as much of the sickle hemoglobin as he had before the treatment. And this treatment has proven to be very successful because thanks to hydroxyurea, now patients have better life expectancy. Another treatment that is also a palliative treatment, which is given to patients to decrease the symptoms of the disease, is transfusion. So what we do is we are going to replace these red cells of the patients that are sick with donor red cells from healthy individuals. And this way we will decrease the amount of the sickle red cells and increase the healthy red cells in the patient's circulation, and this will make the patient feel better. And this kind of treatment has to be regular, so the patient has to be transfused regularly. And of course, the regularity of the transfusion is discussed with his medical doctor. And what we have also is one curative treatment, which is bone marrow transplantation. Red cells are formed in the bone marrow, like all the other cells of the blood. They are formed in the bone marrow. And so what they do is they're going to replace the cells, the progenitors that make these red cells, by healthy progenitors from an HLA-matched donor. And it's very important to emphasize on the fact that you need an HLA-matched donor to get a bone marrow transplant, because unfortunately not all sickle patients have access to an HLA-matched donor. And if we want to speak a bit about numbers, only 14 to 18% of sickle patients will have an HLA-matched sibling to have a bone marrow transplant. And bone marrow transplant is a curative treatment, but it's a very heavy treatment. As we said, that the HLA, you need to have an HLA-matched donor, but even sometimes when you have an HLA-matched donor, you might suffer from graft failure or graft rejection. And this is why it is not used on all sickle patients.
These treatments that have existed in the past have all been very long-term symptom management. And we've seen Casgevy is this new treatment that's kind of taken the whole scene by storm, really. And it's the first gene editing treatment to be developed using CRISPR technology, which people may have heard of. CRISPR is a Nobel Prize winning technology. But could you give us a bit of a background into what CRISPR is and how it works in the case of sickle cell disease?
So CRISPR-Cas9 is a very elegant technology, and I think it has really changed the world of research, and now we see it also in the clinic. So what we do with CRISPR-Cas9 is that you can imagine that in our cells we have different genes. And as we discussed earlier, Lia, is that in sickle cell, this is a mutation in the beta globin gene. And with CRISPR-Cas9, what we can do is we can correct this mutation, or we can change the sickle mutation to something else. Because what CRISPR does is it can cut a part of the genome and replace it with something else. And you can imagine how this kind of technology could be useful to treat a lot of genetic diseases, because you can imagine that you will find the mutation and then you can cut it and then replace it with the healthy gene.
Can it be given to anyone who has sickle cell disease at any point in their life?
This is a very important point, because I know that a lot of patients were very happy to hear about the Cas-JV treatment, and I am very happy that we now have options for sickle patients, because this is really important. But when we look at the eligibility at the moment, and we are speaking today in 2025, and I hope that this will change, the eligibility is limited to patients at the moment who have severe symptoms, but also who are strong enough to undergo chemotherapy. What we do now is we need to harvest the cells from the bone marrow of the patients. So these cells we call them stem cells, because these are the cells that produces the red cells. What we do is we mobilize the stem cells. So the stem cells move from the bone marrow of the patient to the circulation. So then we can collect them easily. We collect these stem cells. The stem cells go to the lab, and then they get, this is when the gene editing happens. So you will have laboratory technicians and experts that are going to perform the editing on the stem cells of the patients. So they will remove the gene or the sickle gene. In this case, in the Cas-JV technique, they are going to be increasing the fetal hemoglobin that we discussed earlier about. And then when these cells are ready, so when they're edited, we're then gonna put them back in the patient. But before we put them back in the patient, we need to clean the bone marrow of the patient, so that when these new cells arrive, they are the ones that will populate the bone marrow. And so this is why some rounds of chemotherapy needs to happen, so that we can clear the bone marrow, and then we will put the cells that were edited, and they will populate the bone marrow back. So this is the process, and if a patient is not strong enough to undergo chemotherapy, this process might be difficult.
The lack of treatment options is, of course, particularly frustrating for patients.
We've got about 3 treatments. So you've got hydroxycarbamide, which is a medication. You've got automated red cell exchanges, which are the blood transfusions. And then you've got the curative options, which is obviously bone marrow transplant, stem cell transplant, and gene therapy. Those are that's what we have, 3. We had, you may have heard, you may not have heard, in recent years, we had a couple of new medications come through, and then they were pulled away because of whether I think they said something to do with patient safety or something like that, but it was put in the news that, oh yeah, this is the new treatment in 20 years. And it's just like, and then people were on it and they were using it and it was working for them, and then it got pulled. There was another medication that was out for probably about 3 months. It came out, was there for, as I said, maybe 3 months, and then it was pulled again. And these are the things where it's just like we don't have not even half of the funding compared to other conditions. So, cystic fibrosis doesn't affect as many people as sickle cell does, but they have so many treatments. And if you say cystic fibrosis, probably most people are going to know what you're talking about. Even if they don't know the ins and outs of the condition, they know it's a condition that affects the lungs, and it has about 10,000 or 11,000 people in the UK, and we have this amount of people, and you only have 3 treatment methods. And for some people, if they can't tolerate hydroxycarbamide, or they cannot have transfusions, because that has happened to a lot of people, and the curative options, it's not everybody that's going to be able to have it.
Yeah.
So with bone marrow and stem cell, you need to have a donor. If you don't have a donor, you can't have it. Gene therapy, yes, it's your own cells that are being edited. However, it's very, very expensive. Same with bone marrow and stem cell. They're very, very expensive treatments.
As we've heard from both Stephanie's own experience and from Sara, sickle cell disorder is an extremely physical disease and can have a serious impact on all sorts of areas of the body. This can be an extremely traumatic experience, so it's not just your physical health which suffers. How does it also affect your mental and emotional state? Because obviously going through something like that, so traumatic at a young age, doesn't just affect your motor skills and things like
Yeah.
that can really affect your mental health as well, and your emotional well-being. So could you talk a little bit about that side of it as well?
So I found out that, if you have like a long-term health condition, like especially with sickle cell, I think I did read something saying that, look, over half of us will suffer from depression in our lifetime. And when you think about it, it does make sense because, you can't do things, sometimes you can't do things other people are doing, or you're limited in doing things that other people are doing. You have to look after yourself because, if you don't look after yourself, the consequence of that is you could end up in hospital or whatever. There's times where I've started my day and I felt fine and I've ended up in hospital either in the afternoon or the evening. And it's stuff like that that does affect your mental health. And I don't think people really understand how significantly it affects your mental health. So I was diagnosed with depression. I think I was like in my early 20s. When you hear about depression, you just think, oh, that, people lay in their bed and they don't do anything and that's it. But depression comes in so many different ways. And it affects people very, very differently. So I would still be happy sometimes and I'll be smiling and I'll be doing things that I need to do. But there was some times where it was just this crippling emptiness, but also just numbness, not knowing what is happening, what is going on. And days that I was just crying constantly, or I didn't want to eat, and yeah, so it was like my early 20s. I had to see a psychologist. So I was self-harming, and this has taken me a lot to say this today. Like obviously people who know, but I'm happy to share it now because I do think it's time for people to know that things aren't easy and it does happen. If you're in an African household, which obviously was what I grew up in, sometimes depression and stuff wasn't, not that it wasn't taken seriously, but it was something that they were like, okay, yeah, it can happen, but you just need to pray. And if you pray, it's going to stop and it's fine. And obviously, you do all of that because obviously that's what you've grown up on. And I was finding that, yes, prayer did help, but I did need also physical help. I needed to speak to somebody. And I was in denial for ages. And thankfully, I was lucky. We had a psychologist that was attached to like our hematology unit, like in the community. So I spoke to her, like I referred myself and stuff like that. And I was with her for 2 years. And I'm so glad that my friend was like, no, you actually need help. And I was so glad that I decided, okay, now, because obviously you can tell people they need help, but things won't change until they are ready to confront what's happening to them and actually seek help. And I'm grateful that I did at that point. I was just like, yeah, okay, I actually do need help because if I don't, this is just probably going to continue. Obviously, depression is also a long-term health condition, mental health condition, but it's long-term. So I'd done like the 2 years and I was like, okay, great. I feel great. That's it. I'm done. And then I think I was so we'd finished the sessions and stuff like that. And I was like using the skills that I had, acquired during therapy. Some people they're going to need to have therapy on and off for the rest of their lives. Like you shouldn't feel ashamed that you're feeling these emotions again. You shouldn't feel, and I was like, yeah, I was doing the same thing, isolating myself. I didn't want to talk. I didn't want to do anything. And I'm just glad that I saw that I understood the symptoms this time and I went back. So now looking back now, as someone who's in her mid-30s, I'm so glad I listened to myself and I'm so glad I did what I needed to do to get help. People don't realize how much your physical health can impact your mental health. Obviously with sickle cell, you need to be hydrated. You need to try and eat well, all those things that will help you. If you're not well mentally, you can't do those stuff to help you physically. So it all works hand in hand. And it is, for holistic well-being, you need to be able to have everything in order for you to be whole as a person.
Yeah, absolutely. And thank you so much, Stephanie, for sharing that. It's a very vulnerable thing to be able to talk about. So also just getting to the stage that you can talk about it is amazing and very brave. So I'm really glad that you've felt that you've been able to do that today. And I think it's a really important part of long-term health conditions in general, like you said, but sickle cell specifically, just to kind of shine a light on that part of the experience as well. Another big part of your research that you look at is moving research from the bed to the bench and vice versa. So I wanted to ask you from your experience, what insights can one lend to another, and why is it important to have that channel of communication from the patient to the researchers?
So this is a very interesting point, and actually it's something I love talking about because this is what got me into research. So I'm someone who really gets enthusiastic about studying pathways and looking at genes and proteins and the function of cells. But I also am very interested in improving the quality of life of patients, and most importantly, finding a cure for diseases. And I think to be able to reach this goal, this end goal, which is curing a disease, you need to be interested in the bench side of things, which is how does the pathophysiology of the disease occur? What is causing the complications, and how can we decrease these complications, or even how can we switch from a disease state to a healthy state? And this is how a clinical observation can be taken to the lab, where we can really dissect this clinical observation and test, use different cell lines, for example, and test a hypothesis. And then from those findings, we can go into this process of trying and finding a treatment. And then the treatment, of course, has to be validated first in the lab, in what we call in vitro and in vivo studies, and then we go to clinical trials, and this is when we take back our knowledge to the patients. And I think this two-way flow between the bench side, which is where you explore the science behind the disease, and the clinical side, where you really are attentive to what's happening to the patient, is very, very important, because this is the only way that we can accelerate treatment development.
Could you talk a little bit more about the work that Red Cells R Us do, and that importance of community groups in the world of sickle cell specifically?
Yeah, so being co-chair, which it's really great, and it's just, I think it's just being able to have people that understand what you're going through. And a lot of these people are older than me, so they've experienced, sickle cell on another level. And when I say that, because obviously it's weird, because it still feels like not much has changed, because of the same things that they were complaining about when they grew up. We're kind of complaining about it now, 20, 30 years later. But being able to support each other and letting people get out of their heads a bit, and also just allowing people to come together, have fun, and not have to think about sickle cell for a bit, even though probably a lot of us are there in pain.
You've described before that patients are the experts in their condition.
Yeah.
So as an expert, if you could have one thing that you'd like people to know listening to this about the condition, if you could narrow it down to one, what do you think that would be?
That sickle cell is a debilitating, serious life, it can be life-threatening at times condition. And I do think that it does need to be taken a lot more seriously than the way it is being dealt with now, because people are still dying, unfortunately, in 2025 in Britain. So this isn't like, oh yeah, we're in a in a country that's developing. This is a developed country with a health service, and people are still dying with sickle cell for one reason or another. And most of the time is like maybe neglect or not being believed is what is causing people's death. And I do think people need to understand that sickle cell is very serious. This is not, it's a condition that affects your whole body, and you can have pain in any place, and it is life-threatening, so it does need to be taken more seriously. The illness is isolating, and a lot of the times you will feel lonely, but just for people to remember that they're not alone, and that we have a fantastic community, and you can always reach out to somebody. So whether it's through, because I have a sickle cell page on Instagram where I talk about my experiences with the illness, but I know plenty of people who have their own social media stuff, and they talk about their own experiences. I just think people should always remember But if you feel like you're lonely or you feel alone, just to remember that you're not alone and that you can always reach out to anybody who has the disorder, and, you know, somebody will help you or give you advice if that's what you needed.
What does the future research landscape look like, and what research do you think will be happening soon that will help us to understand the disease even more?
So I'm very curious to see how we will move the gene therapy part of the research forward. I'm very curious to see when we will implicate the in vivo gene therapy, which means that we don't really need to take the stem cells out of the patient, but rather we just need to inject the treatment, and the treatment should go on its own and home into the stem cells of the patients. So I'm really curious to see this part of the research develop, but also I cannot stop thinking about the fact that we need to develop treatments that are also easier than gene therapy. So we need to try and find medications that we can give the patients that could cure the disease. And I know that a lot of researchers, including our research team, is working on developing this. So I think that this is the way to move forward. We still need to understand the disease more and dig deeper into the pathophysiology of the disease. And one thing that I'm extremely passionate about is understanding how pregnancy impacts the pathophysiology, so how pregnancy is impacting the disease in the patient and the development or the evolution of the disease, and also on the other hand how the disease itself is impacting the pregnancy process. And it's really funny that we're having this podcast today, because just a few months ago the World Health Organization issued the first global guideline to improve pregnancy care for women with sickle cell disease. And I think that investigating pregnancy in sickle cell disease is a very timely topic, and it's very important because we need to find more treatments for the moms while they are pregnant. Because as you can imagine, they do stop hydroxyurea, so they cannot take hydroxyurea anymore. And so we need to really understand the pathophysiology and study the safety of hydroxyurea during pregnancy, because if it's safe, we can also give it to the patients. One important thing that I look forward to is more international collaborations, because when we work together, we are able to really reach the solution faster and reach the advancement in therapies faster. And I think that the more different teams around the world collaborate and try to have European projects together, or European funding together, the faster we will be able to answer these questions.
I asked Sarah and Stephanie for some resources that they trust and use frequently, and have linked all of their great recommendations in the description of this episode. A huge thank you again to them both for chatting with me, and thank you for listening. You may have also noticed what looked like a bonus episode uploaded a couple of weeks ago. We're now going to be uploading some of our favourite talks from our theatre on the second Wednesday of every month. But don't worry, original RI Science podcast episodes are not going anywhere, and will still be coming to you on the last Wednesday of the month, wherever you get your podcasts.